She walked into my clinic on a Tuesday morning in October, and the first thing I noticed was that she still had the posture of someone who had spent decades standing in front of people. Margaret was 73 years old, a retired high school principal from outside Columbus, Ohio. She was not there because anything hurt. She was not there because she was scared. She was there because her daughter had insisted. And Margaret, ever the practical woman, had decided to treat the appointment the way she treated everything else in her life, as something to be handled efficiently and crossed off the list. She sat down, folded her hands in her lap, and told me she felt fine. And she meant it. Her sleep was good. Her energy was decent. She was gardening 3 mornings a week, walking her neighborhood every evening, cooking her own meals, managing her own finances, completely independent, entirely herself. She had come in, as she put it, just to check the boxes. What happened over the next 4 months was not what either of us expected. A routine blood panel flagged a mildly elevated marker. That triggered an imaging study. The imaging study found what the radiologist called an incidental finding, something small, something that had almost certainly been there for years, sitting quietly, causing nothing. But medicine does not have a leave it alone button. It has a referral button. One procedure led to a complication. The complication required a hospitalization. And Margaret, the woman who had walked into my office feeling fine, spent the better part of 3 months navigating a recovery she had never needed to begin. The finding that started everything? Her doctors ultimately concluded it would never have affected her quality of life. It was, in the truest clinical sense, irrelevant to her future. But the cascade it set in motion was not irrelevant at all. My name is Dr. Pablo. I am a board-certified geriatrician with 18 years of clinical experience focused on cardiovascular and geriatric health in adults over 60, and I am telling you Margaret's story because it is not unusual. It is, in fact, one of the most common stories in medicine right now, and it is happening quietly, in ordinary exam rooms, every single day. What I want to talk to you about today is something that most physicians genuinely do not have enough time to walk through with you in a standard appointment. The fact that after the age of 70, certain medical tests that once served you well can begin to carry risks that outweigh their benefits. Not because medicine is failing, not because your doctors do not care, but because the mathematics of risk and benefit change as the body ages, and that math is almost never done transparently in the room with you. Today I am going to walk you through 5 specific medical tests I would personally reconsider after 70. I will explain the physiology behind why the risk calculation shifts, I will share what the research actually shows, and I will give you a practical set of questions you can bring to your very next appointment that will fundamentally change the dynamic between you and your doctor. Stay with me through all 5, because the one I am saving for last is the test that the medical establishment almost never discusses openly, and the consequences of getting it wrong can be permanent. And before we get there, I want to tell you that number 3 on this list is the one that surprises people most. It is a test that sounds almost impossibly sensible on the surface, and the reality behind it is far more complicated than anyone has told you. Before I get into the 5 specific tests, I need to give you one framework for thinking about all of this, because without it, nothing I say will fully land. I call it the age-adjusted risk equation, and it rests on 3 biological realities that change after 70. The first is what researchers call lead time bias in late life screening. Many conditions that get detected through routine testing in older adults grow so slowly and behave so quietly that they would never actually harm the person who carries them. You would outlive them. But the moment they appear on a report, the clinical system responds, and that response carries its own risks. The second reality is physiological resilience. The same intervention that a 60-year-old recovers from in 2 weeks can take a 75-year-old 3 to 6 months and can permanently alter their functional independence. Surgical risk, anesthesia risk, the risk of hospital-acquired infection, all of it scales upward meaningfully with age. The third reality is what researchers call the iatrogenic cascade, a chain of events triggered by a medical test in which each step follows logically from the last, and the cumulative harm at the end of the chain is something no single physician along the way ever intended. One test, one finding, one referral, one procedure, one complication, and a person who was functioning beautifully is suddenly somewhere they never needed to be. Keep that framework in mind as we go through each one. Let us start. The first test to reconsider after 70 is routine colonoscopy in patients with a history of clean previous screenings and no symptoms. I want to be precise here because colonoscopy has unquestionably saved lives and remains one of the most effective cancer prevention tools we have in medicine, in the right population at the right age. The key phrase is the right population. The United States Preventive Services Task Force, which is the body in this country that evaluates screening evidence and sets recommendations, states explicitly that the evidence does not support routine colonoscopy screening in average-risk adults over the age of 75. Their position is based on the recognition that in this age group, the cancers most likely to be found are typically slow-growing, that the time horizon for benefit shrinks, and that the procedural risks are genuinely significant. Bowel perforation, a tear in the colon wall, occurs in approximately 1 in every 500 colonoscopies. In a 55-year-old, that is a manageable surgical complication with a relatively predictable recovery. In a 78-year-old with any cardiovascular history, any kidney impairment, any degree of frailty, that same complication can mean emergency surgery, a prolonged hospitalization, and a recovery that never fully returns the person to where they were. And that does not even account for the colonoscopy prep itself, the high-volume liquid laxative that must be consumed the night before, which in older adults with reduced kidney reserve or any cardiac vulnerability carries a real risk of dangerous electrolyte shifts. I had a patient named Gerald. He was 76, a retired civil engineer from Western Pennsylvania, sharp as anyone I have ever met, still doing consulting work 2 days a week, absolutely no gastrointestinal symptoms. He had completed 2 prior colonoscopies, one at 55, one at 65, both completely clear, not a single polyp, no family history. His new internist, seeing the gap in his chart, scheduled a 3rd. Gerald's prep sent his sodium crashing overnight. By 4 in the morning, his wife found him confused and unable to stand. He never made it to the endoscopy suite. He spent 6 days in the hospital managing hyponatremia, dangerously low sodium, and the disorientation that followed him for weeks afterward was something his family described as frightening. He recovered fully, eventually. But here is the critical point. Gerald never needed that test in the first place. The research supporting continued screening in his situation simply was not there. For patients like Gerald, no symptoms, no family history, consecutive clean scopes, non-invasive stool-based testing offers a meaningful alternative. The multi-target stool DNA test and the annual fecal immunochemical test can both detect genuine warning signals without the procedural exposure. If you have symptoms, blood in your stool, unexplained changes in your bowel habits, pain, that is a different conversation entirely. Get evaluated. But if your previous scopes have been clean and you feel well, ask your doctor to walk you through the actual evidence for continuing. The second test worth a careful, honest conversation is aggressive cancer screening in average-risk, asymptomatic adults past 75. I want to handle this one with real care, because the instinct behind cancer screening is sound, and I am not suggesting anyone abandon vigilance about their health. What I am pointing to is the problem of overdiagnosis, a term that sounds abstract, but has very concrete consequences. Modern imaging technology has become extraordinarily sensitive. It can detect changes at a cellular level that, in a younger patient with a longer time horizon, might represent a genuine threat worth treating. In a patient in their mid to late 70s with other health considerations, many of those same findings represent cancers that are, in the language of oncology, clinically insignificant. Biologically slow, behaviorally quiet, never destined to spread, never destined to shorten anyone's life. You would die with them decades from now, not from them. The problem is that the word malignancy on a pathology report does not come with a speed rating. It does not tell you whether you are looking at something aggressive or something that has been sitting still for 15 years. And so the clinical machine turns on, regardless. A published analysis in the Journal of the American Medical Association examined cancer detection in women over 70 through routine mammography and found that a meaningful percentage of the cancers identified fell into the category of low-risk, slow-growing disease for which treatment provided no measurable survival benefit, but carried real side effects. Similar findings exist in the prostate cancer literature for men. I had a patient, Thomas, who was 78, a retired Navy electrician from coastal Georgia, still sharp, still physically active, still fishing on weekends. A routine PSA test came back modestly elevated. A biopsy confirmed low-grade prostate cancer. His urologist, acting with the best of intentions, recommended radiation. Thomas went through it. Within 8 months, he was dealing with fatigue that he described as unlike anything he had ever experienced, urinary dysfunction, and a quality of life that had fallen dramatically below what it was the day he walked in for that routine blood draw. The research literature, including studies published in the New England Journal of Medicine, is clear that low-grade prostate cancer in older men is overwhelmingly managed better with active surveillance than with intervention. Thomas's cancer was the kind a man his age would almost certainly have outlived. He did not know that. Nobody sat down with him and walked through the math. The conversation worth having with your physician is this: given my age and my overall health status, if this test finds something, what are the realistic treatment options? And what does the evidence say about whether treatment would actually improve how long or how well I live? That question alone can transform the appointment. Now, if you are still with me and finding this useful, I want to pause and ask you something. Write your age and where in the world you are watching from in the comments below. I read every single one. Knowing who is in this community helps me understand who I am speaking to, and honestly, it matters to me personally. Take 10 seconds and drop it down there. Now let us keep going, because we are getting to the ones that surprise people most. The third test is one that sounds, on the surface, like the most sensible thing in the world. Routine cardiac stress testing in adults over 70 who have no cardiac symptoms. Your physician says, "You are 72, let us just make sure the heart is doing what it should." You walk on a treadmill, or they give you a pharmacologic agent that temporarily increases your heart's workload while they monitor the electrical activity. It sounds responsible. It sounds like exactly the kind of proactive medicine everyone keeps telling you to pursue. The clinical reality is more complicated. Cardiac stress testing in adults without symptoms carries a false positive rate, meaning a result that looks abnormal when your heart is actually fine, that can reach 30 to 40% in older populations. Nearly half the time, the test flags a problem that is not there. But the clinical response to an abnormal stress test finding is not to wait and see. It is to proceed to cardiac catheterization, a procedure that involves threading a thin, flexible tube through your vascular system directly into your coronary arteries to examine the degree of any narrowing. This is not a trivial procedure. Complications include bleeding at the access site, vascular injury, arrhythmia, and, critically, catheterization itself can trigger the very events you are hoping to prevent, including heart attack and stroke. And if catheterization finds what it almost always finds in adults over 70, some degree of coronary narrowing, which is nearly universal at this age, the recommendation often moves towards stenting. Here is what the research says about that outcome. The ischemia trial, one of the largest and most rigorous cardiovascular studies of the past decade, published in the New England Journal of Medicine, found that in patients with stable coronary artery disease, meaning no acute symptoms, no heart attack, stenting did not reduce the risk of heart attack or death compared to optimized medication and lifestyle management. The stent carried procedural risk. It carried the long-term need for dual antiplatelet therapy, blood thinners, which carry their own bleeding risk. And it did not improve the outcome. You have gone from feeling completely well to a stress test, to a false alarm, to a catheterization, to a stent, to lifelong blood thinners. And you are statistically no better off than the person who simply walked 30 minutes a day and took a statin. This is not an argument against cardiology. It is an argument for having the evidence in front of you before you begin the journey down that road. If you have symptoms, chest pressure, unexplained shortness of breath during activity, episodes of dizziness, palpitations, that changes everything. Get evaluated immediately. But if you feel well and your physician is proposing a routine stress test simply because of your age, the conversation worth having is, what happens if this comes back with an abnormal finding? And what does the evidence say about where that road leads? The fourth test deserves careful handling because the underlying condition it screens for is real, and the consequences of untreated bone loss in older adults are genuinely serious. I am talking about routine DEXA bone density scanning, followed by automatic long-term medication in active, asymptomatic older adults who have never sustained a fracture. Let me be clear about what I am not saying. I am not saying osteoporosis is not worth treating. Fragility fractures, particularly hip fractures, are among the most consequential events in the life of an older adult. A hip fracture in a person over 70 carries a one-year mortality rate in the range of 15 to 30%, according to data from the Journal of Bone and Mineral Research. This is serious medicine. What I am questioning is the automatic pipeline, a DEXA result showing reduced bone density leading directly to a prescription for bisphosphonate medications, such as alendronate or risdronate, without a thorough discussion of the alternatives and the long-term risks of the medication itself. Long-term bisphosphonate use, beyond 5 years, has been associated with atypical femoral fractures, which are stress fractures of the thigh bone that can occur with minimal trauma and often require surgical repair. The same medications have been linked to osteonecrosis of the jaw, a painful and difficult to treat deterioration of jawbone tissue. These are not theoretical risks. They are documented in the literature, and they disproportionately affect long-term users. Here is the piece of the conversation that rarely happens in a busy clinic. The most effective intervention for preventing fractures in older adults is not pharmacological. It is fall prevention. A landmark analysis published in the British Medical Journal found that Tai Chi practice reduced fall risk in community-dwelling older adults by approximately 47%. That is a more powerful fracture prevention effect than most medications produce, and it comes with additional benefits: improved balance, improved mood, improved cardiovascular conditioning, and zero side effects. Add to that a structured home safety review, removing loose rugs, improving bathroom lighting, installing grab bars, checking medications for dizziness as a side effect, getting an annual vision assessment, add adequate dietary protein. Most older adults are significantly under-consuming protein relative to their lean muscle mass maintenance needs, and sufficient vitamin D, which the Endocrine Society recommends at levels between 1,500 and 2,000 international units daily for adults over 70. There are absolutely patients for whom bisphosphonate therapy is the right answer. Those who have already sustained a fragility fracture, those with very low T-scores at high clinical fracture risk, those with specific medical conditions that accelerate bone loss. I am not dismissing medication across the board. I am saying that an active 74-year-old who has never broken a bone, who is walking and exercising and eating reasonably well, deserves a conversation about all of this before a prescription is automatically generated from a DEXA number. The fifth test, the one I promised you at the beginning, the one that is almost never discussed openly, is routine carotid artery ultrasound screening in adults who have no neurological symptoms. This one matters, and I want you to stay with me carefully through this explanation, because the logic that leads people toward this test is completely understandable, and the reality on the other side of it is something the data reveals in a way that is genuinely difficult to dismiss. The carotid arteries are the large blood vessels on either side of your neck that carry oxygenated blood from your heart to your brain. Atherosclerosis, the progressive accumulation of fatty plaque along arterial walls, affects the carotid arteries as it affects arteries throughout the body, and in some cases, that narrowing can contribute to stroke risk. The reasoning behind screening goes like this. If we find a significant narrowing, we can surgically remove it before it causes a stroke. Clean logic, prevention over treatment, exactly the kind of medicine everyone wants. Here is where the data disrupts that logic. The surgical procedure used to treat a significant carotid narrowing is called carotid endarterectomy. It involves opening the neck, temporarily clamping the artery, and physically removing the accumulated plaque. The procedural risk of stroke during or immediately following this surgery is between 2 and 3% in experienced surgical centers. In older adults with additional cardiovascular risk factors, that risk is higher. The United States Preventive Services Task Force, reviewing the totality of the evidence, recommends explicitly against routine carotid artery screening in adults who have no symptoms, no mini strokes, no transient vision loss, no episodes of facial weakness or numbness, no sudden severe headache, no arm weakness. Their conclusion, in asymptomatic in